Hey guys, welcome to Primer and Practice. Got another EKG case for you here. This one is on ST elevation, and we're going to try to figure out what the cause of this ST elevation is today. So we've got a case study. A 55-year-old male, he comes into the emergency room and he's complaining of chest pain. And his chest pain is off and on during the past couple of days. When asked what makes it worse, he says when he moves around, it tends to aggravate the pain. And if he can sit still, things get a little bit better. The only pertinent history is that this patient smokes 1 pack of cigarettes per day and really no other cardiac risk factors, no known hypertension, diabetes, hypercholesterolemia, those types of things. So because of his chest pain and because he's a smoker and he's 55 years of age, these are all good reasons for us to get an EKG, and here it is. So I want you to take a minute and think about it. If you have to, hit the pause button. I want you to do a complete interpretation on this EKG. And then after you restart the video, we'll go through everything. All right, so here is our interpretation. There's things we need to think about on every EKG. And although we probably have one particular thing in mind when we look at that EKG in this patient's presentation, it's good to be accurate and thorough with all of our interpretation. So we have to think about rate, the rhythm, axis, hypertrophy, and ischemia infarction. So let's go through these really quick, and then we'll get to the cause of his ST elevation. So rate can be determined by looking at the number of large blocks between the R to R interval. So if you can find one like we did here with a QRS complex landing on a dark red line or a solid red line, that's where you want to start. And then with each block after that, you can do the method of counting off. So the next block over, if the QRS landed on that one, it would be a rate of 300 and so on. So 300, 150, 100, 75, 60, 50. Look, we've got a rate of almost 50 beats per minute. This is one way you can figure out the rate. But another great way, hey, just look at the top of the EKG. Listen, I don't like the EKG and computer interpretation for very many things, but the heart rate is often pretty darn accurate. Now sometimes if there's a lot of artifact, maybe not so much. But in this case, you can see that our count-off method got us pretty close to what the EKG computer thought the rate was. So next we need to think about what's the rhythm. So looking at the rhythm, we can look at leads 2 and AVR. And one of the rules of thumb is if the P waves are upright in 2 and inverted in AVR, it's likely a sinus rhythm. So we have a P before every QRS. We have a QRS after every P. The P waves are upright in lead 2. They're inverted in AVR. Looks like a sinus rhythm. And with that rate around 53, we've got a sinus bradycardia. Look at that. 2 out of 5 steps already done. So rate rhythm, next comes axis. An easy way to look at the axis is to look at leads 1 and AVF. And if you think back to Dubin's book, if both of those are upright, it's 2 thumbs up and we've got a normal axis. So this patient has sinus bradycardia and a normal axis. The next thing we want to look for are signs of hypertrophy. And although there is like a gazillion different rules for learning what could constitute left ventricular hypertrophy or right ventricular hypertrophy, let's just keep it simple here. If you were to do the Sokolov-Lyon criteria for left ventricular hypertrophy, that's adding the height of the R wave in V5 or V6, which is taller, and that would be V5 in this case. Adding that to the S wave in V1, is it greater than 35 millimeters? The answer to that is no. Simply put, this patient does not have left or right ventricular hypertrophy. So really, what's the question here? It's all burning. We want to know, you want to know, is this guy having a STEMI? All these other things, sure, they're important, but we got a guy complaining of chest pain, coming to the emergency room, and one of the things you probably noticed when you interpreted that EKG is that this guy's got some ST elevation. And not only does he have a little bit of ST elevation, he's got it in a lot of leads. Almost every precordial lead here has got some amount of ST elevation, and it even extends over into those high lateral leads in lead 1. So what the heck is causing this? Is this guy having a STEMI? Do we need to call the cardiologist? Do we need to get the cath lab team on their way? Well, there's some questions we can ask ourselves to help to determine what the cause of the ST elevation is. So here we go. We can think about this. What's the patient's history and clinical appearance? What leads do we see the ST elevation in? And how much ST elevation is there? What's the morphology of that ST segment? Are there other EKG features that are consistent with another possible cause? Like, does the patient have left ventricular hypertrophy? Well, we've already answered that. No. Are there reciprocal changes? In other words, is there ST depression in some of the other leads while we have ST elevation in others? And last but not least, are the changes dynamic? Do they change over time? Do they change over time? Well, here it is. So what leads do we see the ST elevation in? Well, mainly the precordial leads. That could be an anterior MI, but there's other reasons for precordial ST elevation. So it's not uncommon in some men, and actually most men, to have a little bit of ST elevation in those precordial leads. But I think there's more than that going on. So how much ST elevation do we have in each of these leads? Well, depending on which ones you look at, maybe a millimeter, maybe 2, maybe just a hair more than that. So about 1 to 2 millimeters of ST elevation in our precordial leads. So a real important clue to think about to help you distinguish the cause of the ST elevation is, what is the ST morphology? In this patient, we've got a concave ST morphology. In other words, there's a little bit of a sag, a little bit of a dip in that ST segment. And although you can have MIs with ST morphology that's sagging or concave, it's a little bit less scary looking when it's like that. So we can think of other things that might cause sagging ST elevation, pericarditis or benign early repolarization. So are there any other clues, any other things on this EKG that help us to know what the possible cause of the ST elevation is? Well, if you look closely at V4, we can see that there's a little notch, a little fishhook, so to speak, right there at the J point. This is a sign of possible benign early repolarization. We can also look at those T waves that follow. They're big and they're tall, but we have a gentle slope that goes up into the T wave and then straight down off the back. These T waves are asymmetrical. If you were to fold them in half, they wouldn't match up. And this is another sign of benign early repolarization. The good news is we didn't have any reciprocal changes on the EKG. There was no sign of ST depression anywhere. And with this guy, when we repeated the EKG in 10 or 15 minutes, it looked just the same. So what do we have going on here? Well, if you haven't figured it out already, it's benign early repolarization. Benign early repolarization is an incredibly common cause of ST elevation. And unfortunately, it can be present in about 10 to 15% of the patients who come into the emergency room complaining of chest pain. So it will absolutely be a potential cause of confusion for you when somebody's got a chest pain complaint. But what we typically see with benign early repolarization is widespread ST elevation, and it's oftentimes going to be in those usually healthy young patients under the age of 50. Now this guy was 55, so he's a little bit out of that normal range. It's not impossible for him to have benign early repol, but it's a little less likely. So in those patients in particular, you've got to keep in mind, is it really benign early repol or is it a STEMI? So EKG features of benign early repolarization, widespread concave ST elevation, with most of that elevation being in those mid to left precordial leads, just like we saw in this patient. The notch at the J point, just like the purple circle down there at the bottom, you see a little notching there or a little fishhook at the J point. Think about benign early repolarization. This is best seen or typically seen in V4. Now asymmetrical T waves is another clue. You can see that we've written in the smiley face in this concave ST segment with those gentle sloping at the beginning and come straight down off the back. The ST elevation in benign early repol is also modest when compared to the T wave height. So we've got big T waves, and in comparison the ST elevation really isn't that much. Another clue of benign early repolarization. No reciprocity, that's a big one. You got reciprocal ST depression? That's an MI. No reciprocal ST depression? Well, maybe there's another possible cause. And then there's no progression or change in serial EKGs. If you've ever got a doubt about the diagnosis, repeat the EKG. It's cheap, it's simple, it doesn't hurt the patient, there's no radiation, nothing involved except just a little bit of time. Repeat the EKG. If it looks exactly the same, that can give you a little bit of peace of mind. Well, that's it on benign early repolarization. If you want to see other cases like this, you can go to my Facebook page, primer and practice. In fact, this is where this case came from. So, hope that helps. If you have any questions, feel free to shoot me an email. We'll see you next time.